So thank you, Dr. Fernandez, and take it away.
Thank you for your kind introduction. Good morning, everyone. So happy to spend this Saturday morning with you all. We're going to move along because apparently I have too many slides. I don't know why it's not, it's like I'm frozen. Okay.
There you go.
All right. So I'd like to thank the Administration on Community Living, the Center on Aging, Executive Office on Aging. And today's, why am I, sorry, Debbie. Okay. All right. Today's talk is on the dementia basics. So we'd like to begin with how common or how big is this problem? And it is 1 in 9 persons over the age of 65. Please excuse my washer dryer. You're hearing music in the background. As far as dementia and Alzheimer's go, 1 in 9 over the age of 65 and 1 in 3 over the age of 85. And that is a lot of people, especially in our island where we are having a lot of aging population. This is one disease that is increasing. While the rates of heart disease, cancer, the curve is changing on those diseases, Alzheimer's disease is simply rising, and it's expected to even increase so much greater as we have the silver tsunami that is coming. So as far as Hawaii goes, how big is it a problem in Hawaii? Across the US, we think there's about 5 to 6 million people with Alzheimer's disease. In Hawaii, it's around 27,000 to 30,000. But this number is greatly underreported, because when you ask people and tell them, hey, do you think there's about 30,000 persons with dementia? They'll say, heck no, there's so many in the nursing homes, care homes, foster homes. So what we are seeing is just the tip of the iceberg. And, you know, in an iceberg, the greater majority of the ice is actually below the surface. And there's a whole host of reasons why people are missing the diagnosis, or they're diagnosed late, doctors are catching it too late, families are missing it. So we have underreporting. Now, it's interesting to note, according to the Healthy Brain Initiative, they have found that the diagnosis is delayed by 6+ years after symptom onset. That means someone told their doctor they have memory problems, maybe a family member brought it to the attention, and still it takes 6 years to get a diagnosis. And you might wonder, why is this? And a lot has to do with Alzheimer's is a rule-out disease. Maybe a blood test was ordered or a CT scan was ordered, but the person, try finding the radiology department in Queens. You'll get lost just to find that department. So testing and all of this is often delayed, and the diagnosis is delayed. So what happens in normal aging? I want to cover a little bit about normal aging. We do see there is a slowing of neurons, but that does not affect or impact the brain so much. What reduces is mental flexibility as we age. So persons are not so able to multitask. Maybe when they were younger, they could be cooking, checking their phone, babysitting, doing so many things at one time. But that reduces when person gets older. If they're cooking, that's all they want to do, just cook. They don't want to multitask. They may have word finding difficulties, and that is not too concerning. It's just part of normal aging, what you may call it. They may have short-term memory loss, but it doesn't affect the activities of daily living. And they can often retrace their steps, and if they forgot something, they're able to jog their memory and you know, recall what they were thinking about. So what changes the most and what changes the least? I like to show this slide because it's very important to note that reading changes the least. So you see a lot of elderly, they love to go through the mail. They love to read the Star Advertiser. They want to read the Bible. Reading changes the least. Vocabulary changes the least. So what changes the most? It's visual spatial skills. What do we mean by this? It's like learning a new task, or that spectrum remote control. People can't manage that. Or you may have bought mom a new phone for Christmas, a new iPhone. They cannot get used to learning a new device. Motor speed also decreases when persons get older, so they are a bit slower in moving and getting out of a chair or getting into a car, things like that. So important to note that in normal healthy aging, people can still live independently. Their independence is preserved in all of these activities of daily living, whether it is managing their medications, driving, balancing the checkbook. Now, however, if they never did this task, you can't say, oh, now she doesn't manage her finances. Maybe that person never ever did that. The spouse or someone else took care of it. And remember, for normal aging and healthy aging, memory is intact for recent events. And they would perform normally on a memory test. So this is one of the handouts I have given to you all, the difference between normal aging and dementia. So let's look at what are the 10 signs and symptoms. And this distinguishes normal aging from dementia. So normal aging, you might forget names or appointments, but you can remember them later. In dementia, you have memory loss that disrupts daily life and activities of daily living. In normal aging, a person might make an error once in a while say, doing a checkbook. In dementia, they have complete challenges in planning, solving problems, etc. In normal aging, somebody might occasionally need a help in recording a TV show or setting a microwave. In dementia, people can't do this at all. They have difficulty completing familiar tasks at home, at work, at leisure. In normal aging, a person might be confused about the day of the week, but they can recall it later. In dementia, you have a lot of confusion with time or place. In normal aging, you may see vision changes related to cataract, but in dementia, they have trouble understanding visual images and spatial relationships. In normal aging, you might have difficulty finding the right word. So I may say, give me that, and I may mean the pen, and I may say, give me that. But I know a pen is an instrument to write, whereas in dementia, they may not even know that a pen is to write. So they lose the ability to not only find the words, but even know what the words may mean. In normal aging, you may misplace things, but you can retrace your steps. In dementia, you lose the ability to even retrace your steps and recall what happened. Normal aging, you may make a mistake or a bad decision once in a while, but in dementia, you see decreased or poor judgment. Normal aging, you might find sometimes people are tired of their family obligations and social obligations, but in dementia, you often see a withdrawal from work or social activities. Normal aging, people might have very specific ways of doing things and get irritated if their routine is disrupted. However, in dementia, you often see changes in mood or personality. So what is dementia? It is a brain disorder that causes a decline in memory and intellectual functioning from a previously higher level of functioning, severe enough to interfere with daily life. So that's important to note, that it is from some previous higher level. And this is very unique to each person. So you are looking at that person's baseline. What was their functioning, and if there was a change in that. Dementia is not a part of normal aging. So what are the signs and symptoms? We just covered the 10 warning signs, and I've given you a handout that is from the Alzheimer's Association on the 10 warning signs. So please feel free to share that handout with others. And we're going to watch a video that's going to explain the signs and symptoms of dementia. So what are the risk factors? The single most greatest risk factor is age. You can also have family history, genetics, but that is less common. You've noticed that the risk factors for heart disease are also the risk factors for dementia, like high blood pressure, high cholesterol, diabetes, smoking, heart attacks, strokes. Now, being female is a higher risk, and that's because you have a lot of women outliving men, and again, age comes into play because women make a greater percentage of those over 85. African American and Latino have a 2 times higher risk. Persons with traumatic brain injury, you might, like in Hawaii, we have Samoan NFL players. The NFL has a dementia fund because they know that the brain injuries to players does lead them to a higher risk of dementia. Low level of education is another risk factor. The reverse is that a higher level of education protects you from dementia. And another group that is at risk is Down syndrome. Persons with Down syndrome have a higher risk of Alzheimer's disease. So age is the single greatest risk factor. If you're over the age of 65, it's 1 in 9. If you're over the age of 85, it's 1 in 3. And some people think that it's actually 1 in 2 and not 1 in 3. So there's some debate on that. Now, what's the difference between dementia and Alzheimer's? I'm often asked this question, is it one and the same thing? Is Alzheimer's a type of dementia? What's the difference? So I'd like you to think of the flower world. Let's look at all the flowers we have on the islands. We have orchids, hibiscus, heliconias, bird of paradise. And I might say, hey, I think plumeria is the most common flower. If I look right, there's plumeria. If I look left, there's plumeria. Maybe plumeria is just the most common on the island. In the same way, there are many types of dementia. You can have dementia from Parkinson's disease. You can have dementia from strokes. That's called vascular dementia. Lewy body dementia. There's dementia from HIV. There's dementia from severe alcohol use. But the commonest dementia is Alzheimer's dementia. So it's 60 to 80% of the dementia is Alzheimer's dementia. So as I mentioned, there are many causes, but Alzheimer's is the most common. 60 to 80% of the dementia that we're seeing is Alzheimer's disease. And you can get dementia from so many different things. Even syphilis is on the list. So there are many, many causes. This is another graph showing a pie chart to show the same thing, that Alzheimer's ranks #1. So what is #2? Which is the second most common dementia? It is Lewy body dementia. And dementia from strokes or vascular dementia is the third most common cause of dementia. Now I'm going to share with you a video, and if you are having trouble, please let us know in the chat or unmute yourself, because I'll play it again if you're not able to hear it. So,
what is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination. And in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part. Learn more at www.aboutalz.org.
So that is a beautiful video because it highlights the different stages. And what is important to note is that the oldest memories go last. And this is why families often get confused, because I've had a daughter tell me, "Doctor, Nana's memory is so good. Her mind is so strong. She can remember all these things from her days in the Philippines, growing up in the barrios." And so families think, "Grandma's doing great. She can remember so good. Her memory is better than my memory." So important to note that the oldest memories go last. It is the recent memory. People can't remember what they had for breakfast or what they did yesterday. So what does Alzheimer's look like in the brain? And this is another way of, this is a slide on autopsy after a person has passed away, because we don't do brain biopsies. So this is looking at what goes on in the brain. And as per the video, there are these neurofibrillary tangles and plaques in the brain. And this is how it looks like under a microscope. So when you have cell death, what you are seeing is shrinkage in the brain. Look at a normal brain and compare it with Alzheimer's disease. In Alzheimer's disease, the brain has become smaller in size. There is cortical shrinking. And this is another way of showing the same thing. This is a cross-sectional view of the brain. Again, this is done on autopsy after a person has passed away. You will see the difference between a normal sized brain of a senior and a senior with Alzheimer's disease. The white matter, the white part of the brain, has greatly shrunken. So the early stages of dementia, like we saw in the video, you might have some mild confusion, memory loss, but this often progresses where a person starts to have difficulty in their activities of daily living. They have difficulty with bathing, dressing, and that happens in the middle stages. You often have mood and behavior changes in the middle stages. And this causes a lot of anguish in families, how to handle the middle stage. Daycare is excellent in the middle stage. Now, what about the late stage? That is when a person is mostly in bed. They're not talking much, they're not walking, they have weight loss, loss of appetite. And a good company to consider at this time is hospice, because hospice is not only for persons with cancer. Hospice, also people with dementia qualify for hospice in the late stage. So look, discussing this again, early stages, You have short-term memory loss. Often people try to compensate by writing. They write notes to themselves. They have many calendars. They know they're having some memory loss, and they try to compensate. You might have the person showing up at the wrong time or date, or going to the doctor's office and arguing with the front desk saying, no, my appointment is today. You often see that in the early stage. They may have difficulty multitasking, planning, solving problems. You might see a social withdrawal. They might not want to go out much, knowing that they're having memory loss. And people often ask the same question over and over. So because they're unable to retain the information, they keep repeating themselves and asking the same question. Middle stage, again, as I mentioned, it's very flexible, because it's only 2 years, or it's just for 5 years or 10 years. It all depends on the individual, how long the early stage is going to last, how long the middle stage is going to last. So here, mood and behavior is more pronounced. You might also see wandering in the middle stage, and you got to be careful of that, because persons might get lost. And the Alzheimer's Association, and I'm going to discuss that later, is an excellent resource because they have a wonderful program for persons who wander. Delusions, hallucinations are part of the memory issues or behavior problems that occur in the middle stage. The commonest delusion people have is, my spouse is cheating on me, or someone has stolen my money. These are the delusions that you may see in the middle stage. And the late stage can last anywhere from 1 year, 3 years, even 5 years. So it's very variable and individualized. So this is when somebody has mainly taken to bed and they are not walking much or talking much. They're mostly bed-bound. And you see this a lot in foster homes, nursing homes on our islands. You have many people in the late stages of dementia. So how is dementia diagnosed? Alzheimer's disease is a rule-out disease. So essentially, the medical provider is doing a bunch of tests, ordering brain scans, a CAT scan. They'll do a physical exam, neurological exam. And if they cannot find anything, then they say, oh, we ruled out other treatable causes, like they may test for HIV, they may test for syphilis, look at your thyroid, B12 levels, look at any other cause that may be contributing to memory loss. And if everything comes back negative, often that's when the diagnosis of Alzheimer's disease is made. We do have some memory tests, part of the cognitive assessment. We have the mini-cog, there is the SLAMS, MOCA, and these clock drawing. These are the different tests that a doctor may do in their office. How is dementia treated? You might be familiar with these drugs like Aricept, Exelon, Reminil. They act on the chemicals in the brain, so that the neurotransmitters, they increase the level of acetylcholine in the brain, and that helps in the brain cells communicating to each other. There is another drug called Namenda, which is an NMDA receptor antagonist, and that also helps a chemical in the brain. You have a combination drug called Namzaric, which combines the two. But again, they're back to the chemicals in the brain. None of these drugs is targeting the root problem that we saw in the video, the amyloid plaques or the neurofibrillary tangles. Now, newer drugs are designed to prevent that formation. The newer drugs are looking at, can we stop the amyloid from forming in the brain? Can we prevent these neurofibrillary tangles? So newer drugs are on that pathway. These drugs are on the chemicals in the brain, so they can the cells can speak to each other better. I have one slide on COVID-19, and it's more asking questions rather than answers, because COVID-19 has affected persons with dementia in so many ways. If somebody was going to daycare, they can no longer go to daycare. There is a change of routine, change of habits. Also, to ask a person with dementia to put on a mask, they may not want to put on a mask. They may not be comfortable with a mask or all these other personal protective equipments. There's increased fear, confusion, the issues of testing and not, it's not readily available in the community. And then the bigger ethical questions, who gets a ventilator? Who doesn't get a ventilator? How are those protocols made at the hospitals? The heartfelt reality of inability to visit your loved one in a nursing home. All of the nursing homes have strict visitation protocols. And it's really hard for families now to stay away from their loved ones using FaceTime, Zoom, using all these other modalities to see their loved one because they're not able to visit in person. The issue of dying alone, being in the hospital all alone, not family members' inability to visit their loved ones, and the grief and loss for everybody because the old life is gone. We now have a new normal. And there's just a lot of issues around this, and it will be its own talk, but I just wanted to raise the different considerations of COVID-19 and dementia. So what can you do? What can caregivers do? I have this handout for you all that Debbie sent earlier. This is from the Alzheimer's Association called 10 Ways to Love Your Brain. And this is, you might say this is all common sense, eat good, sleep good, get your exercise, learn something new, read a book. All of these are good for your brain. There is tremendous research that backs each and every one of this. There's tremendous research on exercise, tremendous research on diet. So try to promote this with your loved one. Try to promote these healthy habits of a little bit of exercise. Maybe they cannot do too much, but how about just an evening walk? Every little bit counts, and every little bit makes a difference. What about nutrition? We've given you a handout on the MIND diet, and the MIND diet stands for Mediterranean Intervention for Neurodegenerative Delay. So this is the Mediterranean diet and the DASH diet. It's a combination of two diets that is seen in dementia to slow the progression, to improve the memory. So what is this? We are all familiar with the Mediterranean diet. A lot of olive oil, green leafy vegetables, eat healthy foods, fish rich in omega-3. And what do we want to avoid? You want to avoid the red meats. You want to avoid your fats because there are unhealthy fats. While you may have good fats like avocado and olive oils and coconut oil, you do have unhealthy fats coming from your fried foods, pastries, shortening, margarine. You want to avoid that. So please look at the handout that I have given you on the MIND diet. It explains it very well. There are two sections. The green is on top, and at the bottom, the stuff in red, what to avoid or minimize. Now, what else can caregivers do? Because you see, the drugs don't do so much. All the research on the drugs, whether Namenda or Aricept, what they have shown is to delay nursing home progression, or they have shown to improve somewhat the behavior. But the drugs do not improve the memory greatly. You're not going to see a dramatic improvement. So what we are left with, we've got to use other tools in our toolkit to help a person with dementia. And environment has a huge role to play. So when we're dealing with persons with dementia, you got to think of things right from the glare to the lighting to the noise to, what about a person in a care home or a foster home? Just some staff may relate better to the person than other staff. If a person with dementia gets hospitalized, the change of environment just throws that person into a delirium. They get so confused by change of environment or unfamiliar setting. Another thing you can do in your house is use signs, pictures. Signs and pictures provide environmental cues, and this is really helpful for persons with dementia. Now look at this one. Here you see how the environment, a simple thing like changing the color of the toilet seat cover. Such a simple technique, but it is a valuable tool because in toilets, what we notice, everything is white. And because of the lack of contrast, people fall in toilets, people may be peeing outside the toilet bowl, but creating something just like a change your toilet seat cover gives contrast. This is another simple technique to create contrast. You can use one of those Clorox, the blue stuff in your toilet bowl, and here you have blue water, and that simple thing like this creates contrast in the toilet. You also want to do simple things like adapting activities such that they are failure-free. So what's the meaning of this word failure-free? You want to adapt activities so that it suits the needs and capacity of the person. You want to focus on simple activities that reinforce their self-esteem while preventing boredom and frustration. Now, watching TV is not an activity because you notice that a lot in the nursing homes. All they have done is turn the TV on and the elderly person is just stuck watching TV all day. And we want to be a bit more creative and come up with things that can emphasize and focus more on the remaining abilities, not on the losses. So here is an example I want to share with you on how you can right size an activity. Now, say I have my neighbor's kids for the weekend and I agree to babysit them. And so I decide, now what am I going to do with these kids? Let's make chocolate chip cookies. So I have a 5-year-old, a 10-year-old, and a 15-year-old. What would I give the 5-year-old to do? Now, common sense, you might say, oh, a 5-year-old, let them make the little dough balls. They can mix as well. What could a 10-year-old do? They could measure. They could pour in the ingredients. What about the 15-year-old? Maybe the older kid could set the oven temperature. They could put the cookie tray in the oven. This is common sense. So we do this all the time. Similarly, with persons with dementia, one has to adapt the activity so it's right size. That means you can give a more complex activity to somebody in an early stage of dementia, but as they progress to a later stage, you want to make it more simpler. But you don't want to leave them out. You want them to participate. You want to include them in things and not leave them out, watch TV all day. No, we can adapt the tasks. We can right size the activities. Now, communicating with persons with dementia requires some skill. Number one is we have to speak slowly because it's slower for them to process what we are saying. You want to use short, familiar words. You want to give one direction at a time or ask one question at a time. We want to redirect the person, and I'm going to discuss this as well. There's another technique where you can join, validate, and distract, and that helps. You want to break down complex tasks into simple, small steps. So instead of telling a person, take a bath or take a shower involves so many steps just to get that task accomplished. What is easier for the caregiver is to break that complex task down into smaller little tasks. Another thing to remember is avoid arguing or disagreeing because you're not going to win that battle. So avoid arguing with a person with dementia. A lot of communication is actually nonverbal. language doesn't matter so much, words don't matter so much, but it's the nonverbal communication that matters. So you got to think of your body language, your tone, your touch. All of this plays a role in communicating with a person with dementia. So how important is nonverbal communication? This is also done through research and proven. Nonverbal communication is 93% of communication. That means words and language is only 7%. Finding the right words. So don't worry so much if you are dealing with somebody from another ethnicity or they speak another language, because words only matter 7%. Your body language and voice matters greatly. So now some techniques, some little tricks. One technique that works, and they use this in sales and marketing a lot, is mirroring and matching technique. So when you were working or dealing with somebody with dementia, try to respond to them in the way they respond to you. Consider mirroring their response. So if they say, "Oh, I'm tired," you could say, "Oh, you are so tired." Sometimes people do things like this. You could also mimic that back to them and say, "Hey, let's take a shower now." Just matching and mirroring works. You will be surprised. You can match and mirror a person's tone. You can match and mirror their body language. You can match and mirror even their breathing. It will help you gain rapport at a very subconscious level. Now, what about the validation theory? This is another approach for persons with dementia. In validation, we focus on empathy and understanding. And it greatly can reduce stress, agitation, need for medicines. So we have to remember that you don't want to force the person with dementia to accept today's world and today's reality, because they can't comprehend it. So I'm going to give you an example of validation. John says, "Someone stole my book." Now you could respond saying, "John, you are so careless. You're always losing your book and blaming others." You could tell John, "Go find your book if you lost it." Now, in the validation theory and the validation technique, the correct response would be, "I'd be upset too if that happened to me. I'll help you look for it." So here you validate John's feelings and you help John find his book. Reminiscence therapy. What about reminiscence therapy? This is very helpful for caregivers to, help their loved ones look at times from days gone by. You can do this by looking at photo albums, scrapbooks, and this helps. What doesn't help is quizzing the loved one. Give you an example. I did a home visit in the Kalihi Valley, and the daughter asked Mom, "Who is she?" So the daughter points to me and says, "Mom, who is she?" So the mother says, "Fomai." Fomai means doctor in Samoan. Then the daughter says, "What is Fomai's name?" Mother said, "Ruta." And then daughter said, "Where does Fomai work?" And mother couldn't say Kokua Kalihi Valley. She just said Kokua. Now I told the daughter, there's no need to do that. So she told me, "Doctor, I am exercising mommy's mind. I'm keeping her mind strong. So I'm asking her all these questions." Caregivers, they are doing the best they can. And we need to tell them that quizzing actually doesn't help, because it may increase the agitation or stress. Better than quizzing the loved one is to use photo albums and scrapbooks and reminisce together. Another principle is, when working with persons with dementia, should we reorient them or not? What is correct? What is best practice? Now, in today's world, the best practice is do not correct or try to reorient the person. And this is difficult. This is difficult for family members. This is difficult for medical staff. So let me give you an example. What time is my mother coming? And you know Ken's mother died 20 years ago. Which response is better? A, your mother is dead, Ken. Your sister will pick you up at 4 o'clock. Or B, she'll be here in a little while. Let's get a dish of ice cream while we wait. Today, best practices say B is the better answer. B requires people to shift their thinking and join the person with dementia. You're joining their world. You're not reorienting them to your world, but rather you are joining them in their world. Another technique that works is redirection. Who does this the best is kindergarten teachers. You know, when a kid is dropped off at kindergarten, of course they want to go home. They cry right away. But the teacher is so good in distracting and diverting that child, so they will then stay the whole day at kindergarten. And distracting and redirection minimizes outbursts, minimizes arguing, and all of these challenging behaviors. So I encourage you to try it. Try to distract and divert the elder person with dementia onto another topic. And you can use food, drink, rest, smile. All of these things can help to distract and divert. What about for persons who wander? What do we do for persons who wander? You know, in the old days, they restrained persons. People who wandered may have been restrained, tied to the wheelchair, locked. That's no longer acceptable. So today's best practice says that for persons with wandering, we want to promote exercise. We don't want to stop movement. We want to promote movement. So you can use music, put the radio on, let them dance, let them move, keep the body moving. You could tell the person, why don't you collect the leaves in the garden and collect from this side and put it to that side? That just gives them something to do and keeps them moving because they want to move. How can you remember the pictures I showed you earlier about the toilet? You can use color and paint to disguise things. If I painted the wall and the door the same color, you may not notice the door because if it has the same color as the wall. And this is what they do in nursing homes when they have the memory care units. They disguise the doors, the doorknobs, and things like that. So this is to create safe spaces for seniors. You do have a wonderful resource with the Alzheimer's Association. So for all the caregivers out there, please visit the Alzheimer's Association. They're on all the islands. Every island has Alzheimer's Association, and they have a whole host of services and help and tools for caregivers, whether it's brochures, they have different classes, education for caregivers, there's support groups, and there is a beautiful program called the Safe Return. So what is this Safe Return program? It is a combination of the MediAlert Foundation and the Alzheimer's Association. Together they came up with the Safe Return. And typically an adult, it takes 24 hours before an adult is declared missing, before the police or the first responders go and search for the person. In the Safe Return, the photograph of your loved one will be with all the first responders. They have it in a database. It's in the system. So if a person gets lost or wanders, they can start searching for them immediately, right away, and not have to wait for 24 hours. So this is an extremely valuable program. It costs around $50 every year. So it's an annual fee of $50, but well worth it. They have other programs like Trial Match. You might say, hey doc, how can I get these new medicines? for Alzheimer's disease. We've tried Namenda, we've tried Aricept, we've tried all those drugs and they don't work. What about newer drugs? Could we participate in newer drugs? And Alzheimer's Association has something called the trial match. And trial match looks at, they try to match the person with a study trial that's looking for that kind of participant anywhere across the United States. So it's another wonderful program available. So please do check out the Alzheimer's Association, explore all that they have to offer because they're extremely valuable resource. So this is the numbers. I want you to have these numbers. Please keep the Alzheimer's Association number. They have a 24/7 helpline. So if you're having a crisis in the middle of the night, if you don't know what to do, please call this 1-800 number. It is 24/7 available to families and caregivers. We also have the Hawaii ADRC on all the islands, so please keep this number as well. The Executive Office on Aging, your County on Aging, helps caregivers through the ADRC, so please do call them to find out what other resources and things you could get for your loved one. And now I have left 10 minutes for question and answer. So Debbie, maybe we can unmute everyone and open up for question and answers.
Okay, I do have one question that was asked during your presentation. So someone had asked, at any stage of dementia, can signs and symptoms be reversed?
Can they be
reversed?
They can be slowed. Regarding reversal, you might see reversal using behavioral techniques. You might see slowing, and they have shown changes on the cognitive test. Like say if somebody scored 20 on 30, their score may go up on the MIND diet or other things. So I would try all of this together, using diet, using exercise, using environment. And there's a lot of things for brain health and brain fitness. You will see this again very individualized. So what may work for one may not work for another. And when you see reversal, again, that is what you are experiencing with the person. They may not have gains in like, oh, now they remember everything back. But you may notice that, hey, I've tried all these things and I am noticing that maybe this person now at least dresses or can keep the dress and their activities of daily living. So when we say reversal, you have to realize that dementia affects so many domains. It affects activities, it affects behavior, it affects judgment, it affects problem solving. So you may not see a dramatic this in 9 areas or 10 areas, but you might notice gains in some areas. So please do try your best to use all of the food, diet, environment, caregiver. A big thing.
Oops.
Sorry.
Yeah. Okay, go ahead.
A great technique is the caregiver's behavior matters. The caregiver's response to the person in dementia makes the biggest difference. Because if we can retrain the caregiver in how to interact with the person with dementia, you might notice all those behaviors went away without medication. So you might see reversal in that and say, hey, this person has become so much better. I took away all these drugs simply by the caregiver's technique changing. So improving caregiver skills and caregiver communication is vital.
Okay, thank you. If you muted yourself, then you have to unmute yourself, and I won't be able to control that. But does anybody else have any other question for Dr. Fernandez?
I do have a question. This is Janu. Cassidy.
Hi, Janu.
Hi, how are you? Thank you so much. This is a great session. I just had a question. Is it necessary for a doctor when the doctor knows my mom growing dementia, to what stage it is? But they've never offered my mom a test further, investigate where the dementia is from, like you mentioned in one of your photos or worksheet, that you can test on what kind of dementia you have. And they've never really offered us. Is that something I should request? We're at Kaiser, and we're being geriatric doctor there for about 2.5 years, but they offered us an evening memory pill. I don't know how to say it, DONEPEZIL. Yes. So she's been doing that, but should I be requesting maybe further investigation regarding the dementia?
Okay. You bring up a point that we see very common. What we are noticing all across the U.S. This is not a Hawaii problem or a Kaiser issue. This is all across the U.S. People are having the ICD-9 or ICD-10 diagnosis of memory deficit, memory loss, senile dementia. They're just given some code or some diagnosis, but no one is getting to the bottom or the final diagnosis. And you see that very commonly. You have people on Aricept, but they don't even have the diagnosis of dementia. So when we do our training for health professionals, this is one of the red flags. So we encourage health professionals to watch out for people who are on the drug but don't have the diagnosis. And to families, if you are connected with geriatrics at Kaiser, please do ask them what do they think is the cause of your mom's memory loss, because there's so many types of dementia. Now they might order some more tests. Either you might feel the burden of the test is too much. Maybe it's not easy to get your mom to have a CAT scan. Maybe she may not, some people don't want to be in that machine or find it very threatening, frightening. Some people don't like blood tests. I've had patients who have screamed the roof. You can't even give them a vaccine or collect their blood test. So every person is unique. Every person is different. So you know your mother's capacity and how much she can handle blood tests and other kind of x-rays. So it's good to ask the doctor, what do you think is the cause of the dementia? Just ask that, what is the cause? And let them then tell you what they think is the cause of the dementia, of the memory loss.
Okay, other questions?
Debbie, it's Gary again.
Yeah.
That first question was from me, Dr. Fernandez, and I did like a response on how you responded that the caregiving practice and techniques can make a greater difference in the signs and symptoms. So thank you for that. I was thinking about the mind diet. So wouldn't it be a good idea to start children in on this diet as early as possible? So it's a lifelong practice for them.
Eating healthy is good for everybody at all ages. So I try to increase my olive oil consumption or my fruits and nuts. I always have blueberries in my house. So that is good for everyone. The biggest issue we have with children, I mean, is the sugar. The sugar has crept into everything. The high fructose corn syrup, it's insidious. It's in your ketchup, it's in your yogurt, it's in everything. So, people, that's a bigger issue in children, how to cut down the sugar.
Yeah, I know. It's in the pancake syrup.
Yeah.
You're right. It is horrible. Okay, thank you.
Thank you, Gary.
Okay, other questions?
No?
Yes. Leila Ishiki.
Yeah.
Oh, Doctor, I don't know if I missed this. I'm having audio problems, but I was wondering how can we make sure that my mother is taking her various medications?
How is she taking? How can they make sure the mom is taking the medication?
Yeah.
Okay. A very good technique is a pill box. You can buy a pill box at Long's, the Monday, Tuesday, Wednesday, Thursday, Friday. And when you visit mom, put all the medicine in the pill box for the full week. And then you will be able to check. There are also people's phones. You can have reminders to take your pills. That's another way to do it. You might have a person with dementia who might be confused on what day and double the dose because they may think, oh, today's Tuesday, and then later think, oh, today's Wednesday. So a pill box is not foolproof, but it helps. You could also have the medication put on a chart or put on a spreadsheet or print it out, put it on the refrigerator. Making a list that is big and visible also helps.
Does she live alone?
During the day.
Can you repeat that? We can't hear you.
Yes, she lives with my sister, but the sister is at work all day. So during the day, she is alone.
And how often? How often does she have to take the medication?
Different medications at different times.
A starting step to see if the doctors could simplify the medication regimen to once a day or just twice a day. Sometimes you realize people are taking pills so many times and it's very cumbersome. So a starting point would be, can we simplify this medication regimen to make it once a day or twice a day? I would start with that.
Okay, other questions?
Well done, Doc, and Debbie. Well done.
Thank you. Thank you for attending. Thank you, everyone, for your time.